My wife texts me during class. That's never great. Okay. So we've reached the point in class where from here until the end, for the most part, it's going to become chronic disease class. Okay. So I'm sorry, Riley. Anybody else in chronic disease? You've already taken it? Great. And this will be super easy. We'll see how well what I'm covering matches what you guys get in that other class. There was a time after Dr. Taylor retired that for a couple of years, I actually was the one that taught chronic disease class. So in those instances, it was practically identical. But we're going to talk about cardiovascular disease, diabetes, cancer, low back pain, and other kind of musculoskeletal things like arthritis and osteoporosis. We're going to talk about aging, okay? And the point of all of that is we've covered a lot of the kind of anatomy and physiology to some extent. We've talked about the effectiveness of aerobic training and resistance training on sort of what these chronic diseases are and kind of overall health outcomes. So now we're going to dig into some of the actual pathology. So if you have hypertension, right? McKenna has hypertension. What is wrong with her? Okay. Daniel has congestive heart failure. What's wrong with him? How did he get there? Okay. And then we're going to highlight that since we should now have some idea of what normal function is. We'll talk about pathological function. And then we'll highlight how we can use exercise and activity to combat very specifically some of those individual pathologies. Okay. And we'll do that for several different diseases. Okay. Okay. So let's talk about cardiovascular disease in the very broad strokes to start with. Okay. This is the leading cause of death. Leading cause of death in the U.S. and worldwide. Okay. That's why it's the first one that we're going to talk about. This is the big one. This is the thing that is going to affect the most people and cause the most deaths. Okay. Nearly 40% of all deaths in the U.S. can in some way, shape, or form be attributed to something having to do with cardiovascular disease. Okay. 4 out of the 10 people that you care about most in this world are going to die of cardiovascular disease. Okay. 4 out of 10. Big deal. Okay. So somewhere between 80 and 100 million individuals have some form of cardiovascular disease. And this includes what we actually know about. So diagnosed disorders. And then we operate, this is a weird epidemiological thing. I don't know if you guys saw, you probably aren't as sort of locked in on these things, which is good as I am. So they released, the World Health Organization released a thing this week where they were talking about, I think we had crossed some milestone of like 6 million deaths from COVID or something worldwide. And then the epidemiologists, they had estimates of what they actually think it was, right? That there were this number of deaths that we know about that can be attributed, but then there's some things that we don't, like people that had it and died and didn't remember they had it. And then you can do the same kind of thing with like people that tested positive for COVID and then people that had it but didn't realize it. So you kind of know the numbers are bigger. Same thing happens with cardiovascular disease. There's lots of people that have high blood pressure or have some kind of cardiovascular pathology and they don't know that they have it. They won't go to the doctor and get tested, either because they don't want to, or they're unable to from that they can't afford it, or something like that. Okay? So if you look at cardiovascular disease, we're going to have about half of all cardiovascular disease deaths are going to come from something called coronary heart or coronary artery disease. That's going to be the first one of these that we're going to talk about, and we'll spend a lot of time on that. We'll then go through stroke and hypertension and congestive heart failure. And you guys will note that when we add all of these things up, right, we're only getting to about, this is about 80%. There's some other things that last 20%. Okay. Other scary stats in the US, there's somewhere north of about 1.1 million heart attacks that occur every year. Most of those heart attacks can be directly attributed to coronary artery disease, and some of it's associated with associated pathologies. Okay? These numbers tend to go up, and part of that's just simply due to the fact that our population is getting older. My parents' generation, the baby boom generation, they're living longer and they're getting older, so this number is going to kind of continue to go up as we have more older folks. Okay, we're going to talk about 5 specific forms of cardiovascular disease. Okay, 5 forms. We're going to do coronary artery disease, stroke, hypertension, peripheral vascular disease. I will warn you guys when we get to this one. I've got a pretty gruesome picture of a foot that has basically a hole in it from lack of proper blood flow. So I'll let you guys know that that's coming. So you can look away if you are like my wife, and that's not going to be great for you. Then we also have congestive heart failure. So we're going to go through all of these and talk about kind of what is wrong with you with each of these, and how can increase in exercise or physical activity play some role in protecting you from these things. But before we do this, we need to talk about atherosclerosis and myocardial infarctions. Okay? Atherosclerosis is technically not a form of cardiovascular disease. Atherosclerosis is, in many ways, it's a process of a thing that is happening to all of us right now, but it's also, in many instances, the underlying pathology. This is the thing that's wrong with you, okay? That is then going to lead to the development of these other kinds of diseases. Okay, so we'll walk through kind of what this is. A myocardial infarction or a heart attack is going to occur when you have a lack of blood flow to a certain area of the heart, and then that may or may not impair the cardiac conduction system. And so you can have a heart attack without ever going into cardiac arrest, but you can have a heart attack, you can get ischemia and those things, and that has some associated symptoms and problems. But then it can also, in conjunction with having a heart attack, you can go into cardiac arrest. So we'll talk about that. So these are things that either lead to or tend to be one of the final outcomes of all of these, but they are not in and of themselves specifically a type of cardiovascular disease. Okay? So we're going to lead off by talking about coronary artery disease. And so I love this picture. I think I've shown it to you guys beforehand, but here is a network of coronary arteries and coronary veins. This is from a heart where they've dissolved all of the cardiac muscle, and they've put this kind of plasticky latex dye into all of these things, and then it kind of expands and gives it some structure. So you can see that the heart is a very, 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 very highly vascular network. Okay? Lots of blood flow going to the heart, okay, which I know we've already talked about. Okay? So when you have coronary artery disease, you're going to have problems in these arteries. And if they're in some of the larger ones, then it can affect all of these kind of little tiny downstream. Okay? So primarily, coronary artery disease is related to and caused by what's called atherosclerosis. Okay? Atherosclerosis is the deposition of fatty plaques on the inside of these arteries. Okay? So it's going to look something like this. And we'll get more into how that happens and what those things might look like in the coming slides. Okay? But you put these plaques inside the arteries, and then when you do all of that, then it narrows these arteries down. It makes it more difficult for blood to flow through them, and it makes the area that a clot could block up in there much, much smaller, so it's much easier for a blood clot to get stuck. Right? And so what happens with coronary artery disease, as the atherosclerosis develops, as we begin to narrow down these arteries and reduce blood flow, then you get to a situation where you get a full blockage in an area, and the downstream cardiac muscle that's downstream of this blockage, is going to become what we call ischemic. It's getting no oxygen. When it gets no oxygen for a long enough period of time, then that cardiac tissue will die. That muscle will die. Okay? And so when you get this blockage and you get ischemia, you are going to very often then kind of have a heart attack, and you're going to experience something called angina. Okay? Experience angina. Riley, I hate to do this, but you guys talk about angina in chronic disease class. Do you remember what it is? Yes, it's chest pain. Okay. Your heart does not have pain receptors. Okay. If I ask Kaylee to smack Devin in the face, it might hurt. Devin has pain receptors on her face. Please don't do that. Okay. I'm not encouraging violence or anything. Okay. Your heart does not have pain receptors. Okay. And so, in normal instances, if I put a blood pressure cuff around your upper arm and I prevented blood flow down into your lower arm for some period of time, it becomes ischemic. You begin to rely on anaerobic metabolism. You build up lactic acid. The acidity activates some pain receptors and it begins to hurt. It begins to burn and ache. Your heart can't do that. Okay? So, in order to let you know that, hey, there's a problem here, it borrows pain receptors from surrounding tissues. Okay? And so, angina pain generally is going to occur in your left shoulder, kind of up into the left side of your neck, and then potentially down into your left upper arm. Okay? So, you get this sort of radiating pain, okay, coming from your heart, kind of up through your neck, and especially in your shoulder. That's called angina. Okay? That's called angina. I usually try to make some dumb dad joke now about, like, you can punch you in the heart. Right? Physically, it's not going to hurt, but I'm sure many of you have been sort of emotionally had pain in your heart or something like all of that. I don't know. So, okay. Let's talk about atherosclerosis. Here is a nice, healthy artery that has no plaque deposition whatsoever. This is not what anybody in here's arteries look like. I'm sorry to tell you that. Maybe your femoral artery does. Okay? My daughter's probably look something like all of this. Okay? Nice, clean, no plaques whatsoever. B, you can see there's been some plaque deposits. We've narrowed it to some extent. And then C is some further progression out of all this. Most of you, okay, aren't quite this clean. You may have some very, very small plaque deposition. I tell you this to illustrate the point that atherosclerosis is a progressively developing thing. Okay, as you sit here, Madison, what are you drinking? Coffee. Is there any cream in that coffee, or is it just like black? What? Sorry, milk? Okay. Skim milk, whole milk, 2% milk? Do you even know? Okay. See, Madison's being good, but there's a little bit of fat in that milk. Okay? A little bit. Okay? You ate, anybody anything fun for breakfast? Like sausage or bacon? I don't know. Dr. Bellers, what'd you have for breakfast? Oatmeal. You guys are so healthy. Nobody went to Chick-fil-A and did something? Okay.
Had eggs.
You just had the whites?
I had a couple of yolks.
You like drink them?
No, I cook them.
You cook them? Okay. Did you scramble them? Are they hard? Like, what'd you?
I scrambled the egg whites and I made like a sunny side eggs or sunny side up eggs.
Okay.
Tell us what you ate.
I had some extra toasty Cheez-Its for breakfast and a banana. I had a little packet. Yes. Yesterday I had, per our conversation last week, I had like 5 Fun little leftover Halloween fun size peanut butter Snicker bites.
Where's some protein in the hell?
Non-existent.
Look at me, Dylan.
The outrage in those minutes. Look at me.
Okay, so I'm a little more probably in this range, would be my guess. If we look, we can see atherosclerosis in people that are like preteens, teenagers, people that are y'all's age. It generally is not going to be a lot. Okay, it's very much going to be related partially to diet, but especially to exercise levels. Okay, we'll get into a little bit more of that later on. Probably what we tend to see, and this plays a role in when you see people that have coronary artery disease, when you see people that have hypertension, that it sometimes takes 40, 50, 60 years for things like this to begin to develop. Okay, this is not an overnight thing. Okay, not an overnight thing. So, in the midst of all of that. Okay, so very, very slowly progressing. So, when you develop atherosclerosis, a couple of things are happening. Okay, part of what happens is this is an immune system response to damage in your arteries. The immune system thinks, the body thinks it's fixing things, when in fact it's fucking it up. Okay, it really is. So what we normally see, and this is going to be, this is not a length of a vessel, this is the same section of a vessel showing progression over time. Okay, so generally what happens is you get what's called a lesion. You get a little nick or a little cut on the inside of a blood vessel. The reason this tends to happen in the coronary arteries more so than a lot of other places is we tend to get lesions in places where the blood pressure is high, so big arteries close to the heart, where blood pressure is highest, okay, and around places where there's high branching of those arteries. Both of those things are going to happen in the coronary arteries, much more so than in other places. Okay? Your femoral artery has high pressure, but it doesn't branch that much. Your coronaries are very, very highly branched. So what happens is, you guys ever watch water like run around an obstacle or something like this place, like in a river, like a rock or something, right? Like, you know how you put rocks there and it goes fast and it creates rapids and it becomes very turbulent flow. That's why around these places where it branches, if the pressure is high, the blood velocity is high, it creates very turbulent flow, and that leads to increased chances for things nicking and tearing the vessels. Okay. So what tends to happen is we get a little cut, a little nick on the inner lining. That lining, remember, you guys, is called the endothelium. Okay. So what begins to happen is in that nick, we are going to get the accumulation of essentially LDL cholesterol. It may stick there. As that happens, the immune system is going to mount an immune response, and you're going to have these white blood cells called macrophages that will come in and they will start trying to repair things. And they send off signals to call in other white blood cells, other macrophages. Okay? So what begins to happen then is we're going to get from this sort of macrophage infiltration, you form with these LDL molecules something called a foam cell. And a foam cell is basically, you get LDL in the nick, the macrophage eats the LDL, and it can't break it down. So it just sort of is like, fine, the cell's just like, I'm just gonna like consume it and sit here on top of it and die. And it's just stuck there, okay? That's a foam cell. So it's the immune system's way of, we can't clear this out, so let's just sort of cap it off and then forget about it in some ways, okay? We had a friend, sort of an aside that I think kind of makes the point. Good friend told my wife that we would not be ready to have kids until you can be okay with the fact that someone threw a hot dog behind the seat of your car and left it there for 6 months. And that those are just things that happen. Until you're ready to deal with that as a fact, like it gets stuck, food gets stuck in places, and you forget about it. You go like, what's that smell? It's a hot dog behind the seat that's been there for forever. Until then, you're not ready for kids. Okay, I can attest to that. Right, I'm way more okay with things being dirty and getting left. And my daughter, like, there's just stuff everywhere. We found something this weekend, like under our couch, and it was not food. It's been there, I don't know, a long time. And that's kind of the idea behind the foam cell. Eat the LDL, and then we're just going to form this thing and forget about it and hope that nobody ever notices. Okay. Well, as this happens more and more often in similar places, then you're going to begin to kind of around those foam cells and things, you're going to begin to have more and more of these things kind of get clumped together. And that forms a thing called an intermediate lesion, which at that point, you're going to have what looks like a bit of a fatty plaque. Okay. You've got a little bit of these things that are forming. Generally, these things aren't going to start happening until your third decade of life. So in your 20s, okay? In your 20s. It takes until then for all the Doritos that you've eaten, in my case, to come in. Okay? As this continues to progress, then you can form something called an atheroma, right? And this is going to be where you're getting foam cells, but then eventually at this point, we're going to begin to accumulate additional intracellular lipid kind of in and around all of this. You're going to get more and more cholesterol deposited into these things, okay? As that begins to happen, you're going to get macrophages and platelets. They're going to activate smooth muscle that sits on the outside here. It's going to become very, very kind of fibrous and tough, okay? As that progresses, and this is kind of into your 30s and 40s then, if this is happening, you may then move your atheroma into something called a fibroatheroma, which the final thing is we can't get this off. So let's put a fibrous cap then on top of all of it and try to sort of cap it off again and then not have to deal with it. The problem is that once we've done all of this, there's already now been significant narrowing of this artery. And by putting this thick, tough, fibrous cap on, then it becomes very inflexible, okay? It becomes very stiff and inflexible, which is not good in an area with high blood pressure because there's no elasticity to sort of help deflect those pressure waves that are coming around, okay? Once that then can progress, you're going to get what's called a complicated lesion, and then eventually, right, that fibrous cap can become compromised. And when that happens, the fibrous cap can break off and form and become what we would call an embolus, which is in essence a blood clot. So you can form all of these things. It can narrow the arteries. And then in some instances, then pieces of the plaque will break off. And then they can get stuck in this narrow area. And now you've had a blood clot, you've got complete lack of blood flow in these particular areas. Or even if it's big enough for it to get around here, it may break off and get pushed downstream into a smaller artery and get stuck there. So there's a lot of things that are going on with all of this. Very good. Y'all talk about this at all in any of your other classes? Rather than talk about this, y'all talk about this in chronic disease? Other than like these things happen and it forms things?
Yeah, not really like in depth.
Not really in depth. Okay. Good. You all didn't do that in Cuban Fizz or anything? A little bit? Okay. I'll have to ask my grad student. There's an upper level biology class and some kind of pathophysiology, something I need to ask police if they go through all of that. Yeah. Okay. But this is what happens, but you also need to appreciate that this takes years and years and years and years. And one thing that I've not really mentioned in the midst of all of this, but you will note that you're getting all of this cholesterol deposited in there. It's primarily LDL cholesterol that gets stuck. That's why LDL cholesterol or elevated LDL cholesterol levels are a risk factor for cardiovascular disease. If you don't have the LDL, okay, Dylan and his eggs this morning. Guess what? He's told me I don't have any protein. Guess what else is in those eggs? LDL, cholesterol, and some things. Okay, then potentially that may play some role in preventing the development of this. Additionally, people that get this, they have this kind of chronic elevation in immune system activation that's going on here. So you've got all these macrophages and other immune cells that are going deep. And that seems to be associated with obesity. Okay? People that are obese have elevations or higher levels of this kind of chronic inflammation everywhere that also seems to predispose them to the formation of these things. Okay? So when you take things like antioxidants, when you take things that are anti-inflammatory, okay, you drink orange juice, you eat vegetables, you eat fruit, and the like, then that can also help to alter the kind of overall environment that may limit some of this, even if you're doing nothing but eating Doritos and chicken fingers like I do. Okay, exercise does some of the same things. We'll talk about that in a few minutes. Okay, so at some point on my deathbed, I will probably be like, oh, I shouldn't have eaten all those chicken. Okay, so here's a coronary angiograph. So this is the heart, right? These are the coronary arteries, and then what you can see here is they run dye through them, and so where there's not going to be, where the dye can't get through, then it looks like there's almost no blood vessel. And so here is blockage or atherosclerosis, so very clear coronary artery disease in the left anterior descending coronary artery. So it would look normally like this over here. And this is what it looks like now. What I actually think that they've done with these is this was an initial one, and then this was after they had restored some flow, kind of right there. So that looks a little bit different. They try to put a stent or something in and restore flow. Okay, but you can imagine that as this thing gets pinched off because it's narrowed down, there's very little blood flow, and so some of the things downstream of there are also not proper. Okay, so we've already talked about this a little bit, so we don't really need to go into too much more detail, but having a heart attack can be due to prolonged ischemia. You get death of this cardiac muscle, and then as the cardiac muscle dies off, then ventricular function especially is going to suffer, okay? So if you're losing muscle in your ventricles, then your force of contraction is not going to be as high, your stroke volume goes down, your cardiac output goes down, and that can create a lot of problems. It also makes the other cardiac muscle have to work harder in order to kind of maintain flow and output from there. That can also be a problem. Okay? So that's what's happening when you have it. So, okay, let's move away from that. We're going to talk about something called stroke. Okay. Anybody know anyone that's had stroke? A couple of you guys have. Check it out. So, a stroke is like a heart attack, except it's in your brain. So it's a lack of blood flow to a particular area in your brain, or an interruption in blood flow to a particular area in your brain. Have one, and you need Eric Shepard to come fix your head. Watch Grey's Anatomy. That's basically all Eric was doing. They're fixing blood flow issues in people's brains. And yes, when they do surgery for these things, you are awake. Like you don't have any pain receptors in your brain either. So you can be awake while they operate on you and you just don't feel anything. So it's wild. So my mother-in-law, before she passed away, she had brain tumor. And they did surgery on her to take the brain tumor out. She was awake while they were doing surgery because they were like checking function in other places while they're doing it. They give you some local so they can make cut into your head, but the skin part doesn't really feel it. Once they get in it, you don't feel it. It's wow. Okay. So we break down the types of strokes based upon the cause, the root cause of the stroke. So there's two kinds. There's an ischemic stroke, and then there's what we call a hemorrhagic stroke. Ischemic strokes are the most common. And with an ischemic stroke, what happens is you get a blood clot that gets stuck in a cerebral artery, and it blocks blood flow downstream. And so when you block blood flow downstream, then you alter the metabolism in those neurons, and potentially if they can't make enough energy for a long enough period of time, then those neurons can damage, those neurons can die. Okay? In a lot of instances, ischemic strokes are the result of atherosclerosis in the cerebral arteries, and or an atherosclerotic plaque getting stuck in a cerebral artery. A hemorrhagic stroke, functionally, we end up in the same place. You're going to get a lack of blood flow to the brain. But in a hemorrhagic stroke, what happens is the blood vessel ruptures. A cerebral blood vessel ruptures. It tends to rupture at a thing or a place called an aneurysm. Okay? Aneurysms are weak spots in blood vessels. If you watch a lot of medical shows on TV, they say, oh, the person had an aneurysm. What they mean is they had a stroke, but it occurred at an aneurysm. Okay? So I just want you guys to kind of keep all of that in mind. So the blood vessel ruptures, blood flows out of the vessel and increases the pressure in the surrounding tissue. It puts pressure on the brain, and you can either get damage to neurons directly from that increase in pressure, or more likely what happens is that increase in pressure shuts off the ability to get blood flow into that area. The pressure gets so high that it exceeds systolic blood pressure, so you can't get blood into the brain anymore. In that instance, then you're going to wind up in the same place. You've got neurons that aren't getting a sufficient amount of oxygen. They can die, and you're going to get these very clear changes in function in response to all. Okay? So ischemics are much, much more common. I think they're like somewhere between like 75 and 80% of strokes are ischemic. Hemorrhagic ones tend to be much worse when you actually get one. Here's an aneurysm. Okay? So a place in a blood vessel where the wall is very, very weak. So you can see it wants to sort of balloon out like all of this. So you can imagine that it doesn't take, given where this one is, it doesn't take a lot more for those things to be able to work. Right? Anybody have anatomy here and on your cadaver have a particularly noticeable or pronounced aneurysm that you guys can see? Like you can get them anywhere in blood vessels. Some cadavers and things, like you can see them in like some of the large arteries, sort of in the chest and those things. So you can have these things for a long, long period of time and never have them. Okay. So somewhere between these days now, like 3 and 5% of the population has had some form of a stroke. Stroke really, really increases in incidence or prevalence when we get over the age of 60. Right? It takes a long time for blood vessels to get to a place where something like this can happen. Okay? It's very, very rare that we see strokes in younger adults. It doesn't, I mean, it will happen, but it's relatively rare. So really kind of crazy things. This is the 4th leading cause of death. It is one of, it's not the number one, but it is a leading cause of adult disability. Okay, so like every 4 minutes, someone dies from a stroke, right? We have about 800,000 strokes each year. Most people are having their first stroke. But about a quarter of people, if you had one, you're at a very, very, very increased risk to having another. My paternal grandmother had 3 before she finally passed away. She survived all 3. They were relatively minor, but they think that she had Okay. So I was wrong. I was said like 75 to 80%. It's actually almost 90% of strokes are ischemic strokes, which is good in some ways because those are the ones we have the best chance to try to. Okay. The reason that strokes tend to cause disability is when you get damage to neurons in certain areas of the brain, neurons don't come back. Okay? It's very hard for us. We can't regrow nervous system tissue. And so you have this, you have impaired motor function to a place, you have impaired speech function. And so we can do what we can to try to train you back, right, to a place to be able to do things. But we can't always get you back to where you were initially. Okay. So we'll talk about a risk factor now for stroke. It's really a risk factor for all of our kinds of cardiovascular disease, in addition to actually being the disease itself. That's hypertension. Okay. That's hypertension. So hypertension or elevations in blood pressure, okay, very often has no symptoms whatsoever. If we had everybody in class today, we might have one person in class that has somewhat slightly elevated blood pressure. In general, it would be one of the guys, okay? They would be probably right on the border. We don't often see this in folks that are y'all's age, but you can, okay? So if you have, in some ways, unexplained headaches, vision problems, potentially difficulty breathing that can be due to some things going on, fluid in and around the lungs, if you feel fatigue, if you have chest pain, pounding in your neck, chest, or ears, okay? If you have blood in your urine, things, all of these can potentially be caused by hypertension. The problem is, unless you get it checked regularly, very often there are no symptoms. You're fine, you just have all these things. Okay? So, and the problem why it causes headaches and vision problems and these things is that this elevation in pressure can press on nerves and increase fluid accumulation in certain places, and that pressure is high. You may have blood in the urine because you're filtering so much. So I kind of like the colors and kind of the way they're breaking all of this down. I know we had mentioned kind of what the cut points for hypertension were previously, but it's not always that simple. It's not just simply 140 over 90. We actually break these things down into like stage 1 and stage 2 hypertension, into what we call pre-hypertension. And the reason that we do all of this is if you're pre-hypertensive, they probably won't put you on drugs, but they might encourage you to change your diet and your physical activity habits. If you're a stage 1 hypertensive, they're going to start you with, let's do diet, let's do exercise to try to treat some of these kinds of things. And by the time you get to stage 2, that's when they're really going to begin and do a pharmacological intervention. Okay, so we've got systolic pressure here on the Y, diastolic pressure on the X. And so you've got like 90 over 60, somewhere at 90 over 60 or below on either of those, you're considered to have low blood pressure. Okay. Usually having lower pressure is good. If it gets to be too low, that can also be potentially good. The green area, so systolic between 90 and 120, diastolic between 60 and 80. Green area is considered normal. Okay. Somewhere in the kind of that band is normal. 121 to 139 and 81 to 89 are considered pre-hypertensive. If you're in this orange range, you are at a significantly elevated risk of this eventually becoming hypertension. And when I say significantly elevated, basically, if you don't do anything, you will have hypertension at some point. Okay? And then, so 140 to 160 and 90 to 100, this is stage 1. And then, in many ways, everything over is considered stage 2. Okay? So, these are all, in some ways, degrees of not great to bad, and we treat them as such by using different kinds of interventions. Okay. So these are some I think really visually striking sorts of data. Okay. And so don't really worry. These were published in the mid-90s. They're grabbing some data earlier. We can recreate this using some of the most recent data from this NHANES data set, the National Health and Nutrition Survey that we have, but the pattern is roughly the same. Okay, so this is the percentage of people in these age buckets that are hypertensive. So in y'all's age range, like 4% of people are hypertensive. If you look at people that are 80 years older or above, right, they're at almost 70% of those people, or about 2/3 of those people are hypertensive. And so if you take everybody, like all adults, and you get an average, in 2008, kind of somewhere a little after this had come out, the average was about 30% of people. But what I want you to know, right, the average is really driven by these older individuals, very, what we call a bimodal distribution. Right? Young people are not hypertensive, and practically all older people are hypertensive. Okay? This is driven by, it takes a long time for atherosclerosis to develop. Okay? It takes a long time for it to develop. That's why it takes a long time for hypertension. What causes hypertension? I'm going to be really honest with you guys, so please don't cancel me on like social media. We don't know. Okay? We don't know. We have some ideas. We know some things that are going to be related to it. But a lot of hypertension is what we call essential. That means that it has an unknown origin. Okay? An unknown origin. Phoebe is hypertensive. Maybe it's because of her age, although in Phoebe's instance, probably not. Unless somehow Phoebe, is like 80, but looks like she's 20. Okay? That would be wild. It's possible. Okay, we know it's related to obesity. We know it's related to physical activity levels. Okay, we know these things play a role in the development of atherosclerosis. All of these things are intertwined. For some people, it's related to salt intake. The professor that was my mentor for my master's degree, if you gave him a little small bag of plain Lay's potato chips, and he ate them, within an hour, his blood pressure would go up about 15 millimeters of mercury. Okay? So we would have lab meetings, and he would bring these terrible, awful, unsalted chips, right, and want to eat those things. And I ate them, but I didn't enjoy it. Right? In that way, it only seemed like he brought them. We should all partake. But some people are very, very sensitive to salt intake, and that is related to kidney function. Okay? I don't know how much you guys talk about this in human physiology, but I had a graduate class, my graduate physiology course that I took as a PhD student. The person that taught our renal section liked to tell us that the kidneys are the thing that determines your blood pressure. We would sort of argue with him and push back a little bit. But kidney function and what happens at the kidneys, your ability to filter and either get rid of water and sodium, are very much related to blood pressure. Okay? If you are a person and you eat more salt, okay, that increase in salt intake alters kidney function and you make less urine. Therefore, you're hanging on to more water in your blood volume stays higher, therefore your blood pressure stays higher. Okay? So people that have improper kidney function can oftentimes be higher. The one thing that's not on here that I really should have put on here, you guys want to guess what it is? Anybody have a parent that has high blood pressure? I mean, yeah, if you're diabetic, it's probably. But Kelly, you have a parent that has high blood pressure? You're at an increased risk because of your parent, right? Genetics is and your parent probably has it because their parent did. Okay, so I am at an increased risk because my mom is mildly hypertensive. Okay, her dad and her mom were both hypertensive. It's just genetics. Okay, I say all of this, and I'm like, man, I gotta change the way that I live. Stop some of the things that I do. That's the other thing that's not on. Okay, it runs in families. Right? It runs in families. Very much so. as does obesity runs in families. Atherosclerosis runs in families. Kidney function runs in families. It's hard for us to tease out individually with any one person. Is it this, or is it this, or is it this, or is it this? But one of the primary treatments for hypertension is lose weight, become more active, eat less salt. Okay? My father-in-law, for like 10 years, did not want to go on medication for all of this, so he would try to come back. He's mildly hypertensive, and he has elevated LDL cholesterol, which we'll talk about probably next week. And he didn't want to go on medication, so he would also try to, kind of moderate some of this. Let's go. Okay. Let me see. Let's go ahead and let's go ahead and take our break here. All right. So we'll come back at 11:35 by that clock. If you're on T-Mobile, it will be 11:39. I'm glad our clocks are off. We have to set them. Okay. So peripheral arterial disease or peripheral vascular disease, much like a stroke is a heart attack in the brain, peripheral vascular disease is coronary artery disease, but it's in arteries that are like in your feet or in your ankles that are way away from the heart. But it's the same, it's really the same idea and the same pathology. You get atherosclerosis in these places, okay? And it decreases blood flow. And when it decreases blood flow there, you get ischemia, you get the accumulation of hydrogen ions, and it hurts, okay? And it hurts. And a lot of the time, one of the things that exacerbates this, okay, is movement, is using those muscles down there to your feet, because you need more blood flow when you're having a hard time getting it. Okay? So arteries narrow. This occurs in about 12 to 15% of the population. Okay, they narrow and you get this pain. We call the pain claudication pain. Okay, I don't know what a claudication is. I don't know why they call it that, but that's what it's called. If you take exercise tests and a prescription, and you look in the American College of Sports Medicine's guidelines manual, if you want to sit for one of their exams to get a personal trainer or a fitness specialist certification, they have a particular scale that you would ask a person. You do a stress test on them, put them on the treadmill. We're going to estimate your VO2 max. We're going to see if you have angina, and we have a really terrible scale for asking about if you have claudication pain. As someone that studies pain for a living, their scale is awful. It's like 1 to 4, and it has bad verbal descriptors. Like it is in no way, shape, or form sensitive to anything. That's what people use. Okay. The place where this is really prevalent, okay, it only affects maybe 10 to 15% of the total population. It affects 1 in 3 diabetics. Okay, 1 in 3 diabetics. You guys will see when we talk about diabetes next week. If you're diabetic, especially if you're a type 2 diabetic, you're going to have high blood pressure. You're going to be at a really high increased risk of peripheral arterial disease. You're probably going to have coronary artery disease. You're at a marked increase of having a stroke, right? The cluster of symptoms of all of those things is really, really, really not going to be great. And so you may think, well, Dr. Black, that's fine. My leg's not going to fall off, like whatever. It hurts when I exercise. What can we do about this? Well, one of the big problems, we're going to lead into the next slide, is poor circulation means wounds will not heal. Okay? It means that wounds will not heal. And so you can get gangrene in your foot. Okay? You get a lack of blood flow. You can't get immune cells there. Okay? The tissue does not have enough vascularization to help it repair. Okay? Then you can get a thing that looks like this. Okay? Any of you guys want to be occupational therapists or physical therapists, if you work in inpatient settings, in hospitals, if you want to be a nurse or something, you are going to see things like this in people that are bedridden, and it's older in the midst of all this. They have a lot of trouble with having their wounds heal. Okay? Wound healing is very much compromised. Okay? So those things, you guys ever heard something called a bed sore? Right? People that are like that have to sit in and lay in bed. As much fun as we think that it might be, just like I'm gonna lay in bed for like 2 straight weeks, just watch Netflix the whole time, right? Seinfeld's on there and blow through all of that. I don't know what else y'all are watching, Squid Games, whatever it is. Okay, blowing through all those things. People that are, you guys can move around, you can wiggle, some pressure feels weird, you can move, you can do things. In people with compromised motor function, people with compromised sensory function, they lay in bed and they get pressure in areas and it cuts off blood flow to those areas. They develop what are called bed sores. And it's just areas where it's like they have a wound and they get a blister or something and then the skin doesn't heal. Okay. And it can be a real problem. Guy that I did my PhD with had, before I got into the lab, he had a car accident and had sort of a mild brain injury as part of all of that. And so he kind of had stroke-like symptoms. So he was in a wheelchair and he had to sit a bunch and he didn't have great kinds of things. So he would get these bed sores in his butt. And because he was in many ways very, very brilliant, he would take our electrical stimulation pads, we did a whole bunch of these in the lab. He would put them around the wound since he couldn't move very well there. And he would basically make his glutes contract, and it would, within like a week, it would magically fix the bed sores and those kinds of things. It really promotes blood flow and healing in a lot of different ways. And so that's becoming a really big deal. Is that these are things that happen when people are in the hospital for a long period of time. You can imagine these people that have COVID and are on ventilators. If we can manage, they lose like 50 pounds, they lose all of their muscle and stuff, they're also going to have bed sores. It's just a really, really kind of terrible thing. And this is going to be part of kind of how we rehab them and help them kind of help them. Okay. All right, I'm going to talk about congestive heart failure, and then we're going to quit for today. We'll finish off the kind of last little bit of things about the interaction with obesity and stuff next week. And just like maybe we're not feeling it today, so we'll try to reconvene on Monday when things are better. So I love this image because I feel like it really, really captures what happens with congestive heart failure. Okay? With people that have congestive heart failure, your heart is too weak. Your left ventricle is too weak to pump blood properly. In some instances, it can be your right ventricle. Okay, but it's a disease. It is progressive. It develops over time. It oftentimes develops after people have had 1 or 2 or 4 heart attacks, and they've had so much ischemic damage to the cardiac muscle that's not strong enough. Okay, so what happens is when the left ventricle cannot contract forcefully enough to generate a sufficient amount of pressure to overcome pressure in the aorta, then blood has a hard time leaving the heart. If blood can't get out of the left ventricle, then blood can't get into the left atria coming back from the lungs. Okay? Vice versa, if you've got problems on the right side of the heart, then you can't get fluid, you can't get venous blood back into the right atria. And so when you have congestive heart failure, you tend to get peripheral swelling in people, or you're going to get swelling in your pulmonary swelling. You get stuff that backs up, we call it sinus congestion, backed up into the lungs. That's also not. Okay. It affects 1 to 2 million people. Mortality rate's really, really high. If you get to a place where you have congestive heart failure, it's about 50-50 how long you're going to live. Okay. And so when we get to that particular place, it can be really, really bad. The good part about trying to combat this is that if you have a heart attack and you get damage to your cardiac muscle from ischemia, if we send you to cardiac rehab, if we clear up the flow problems, when you go to cardiac rehab and you make your heart continue to work harder, cardiac muscle can come back. Okay? You can repair, you can regrow, you can hypertrophy cardiac muscle. It's like skeletal muscle, it's very plastic. Okay? Unlike having a stroke, say, where when neurons are gone, the neurons are gone, they're not ever coming back. So we're hopeful that we can combat some of this simply through the use of exercise. Okay, so we'll stop here. We'll stop here. You guys have a good weekend. Okay. Who we got in football this weekend? Ayler. Ooh, okay. This may be another week of the season where I will root for us. Not a big fan of Baylor. Okay. Is it here or is it in Waco? Okay, well, if you're going, say hi to Chip and Joanna for me and go see the silos and hopefully we win.